It's really, well, thank you, Marissa. It's really the panelists who are the experts here. And we'll have a conversation about housing. We'll probably spend more time on homelessness and maybe touch upon the continuum into self-sufficiency and home ownership. But I do want to thank our panelists for your expertise and your time. It was fun to sit in the middle, and I was listening to our government. I'm putting Fred in government in DC. They're talking about some of the movers and shakers, sort of the policy, you know, the folks who you talk about, Sean and others. And I hear over here the conversation is about the client challenges and the actual programmatic operational challenges. So it's always a great partnership between government as policymakers and funders, and nonprofits often as the hands making it happen. And it doesn't happen without that partnership, and it doesn't quite, frankly, doesn't happen anymore without philanthropy, without the business community. So all of that investment is needed to achieve the outcomes that we're hoping for, the interventions and the return on investment of those interventions. So I think today we're going to be hearing from a number of perspectives, probably a high-level policy, longitudinal, historical context that Fred can provide from that very high level, and then drill down. And then certainly Brande's got some expertise in that partnership with local government and where you fund and why, what's working, what might need some further work. And then I call my on-the-ground peer practitioners, Dede and Mattie, who really are running programs that we've got to know what is effective, how do we continue the investment or funding for that, how do we measure and evaluate the outcomes of that, and what is missing. So we want to give you that perspective as investors in so many important human service endeavors in Arizona. What is happening in housing, what's working, what maybe is problematic, and where can you make a difference? So I think probably we'll start with Fred, that high-level overview. Fred is the wise sage, right? And though sometimes those wise sages, so at some point I may start to strangle him a little bit if he's getting too far off track, but Fred, I'll turn it over to you.
So I mean, I think it's important as we have this conversation about sort of what's changing in the world of homelessness assistance. It's just sort of coincidental that tonight I'm leaving to go back to Washington for the 30th anniversary of the National Coalition for the Homeless, that I ran in the early 1990s. And the fact of the matter is, we're not actually celebrating that we're still around, but rather recognizing that they've done 30 years of good work, and we're just comparing a number of organizations that sort of have their 30th anniversary coming up. So I think it's important as we have the conversation about what's happening now to have a little context in terms of of how things have evolved. And so I think very few people remember back in the early 1980s here in Phoenix, one of the first studies in terms of trying to count the number of homeless people actually happened here. The Salvation Army, Louisa Stark was hired to do that, and we actually crafted this sort of idea of a three-tiered system: the emergency, transitional, and permanent housing system, which became the sort of common language during the 80s and 90s. It was sort of codified in 1987 with the passage of the McKinney Act, which then actually focused on the transitional and permanent housing side of things. And I think as we begin to talk about how we want to change the system now, we need to recognize that there never was an intent that there would be this sort of progressive. We hear the word continuum, and we think progressive, beginning at emergency and working your way from emergency to transitional, and then working your way 2 years through transitional, and then you get awarded the opportunity to have permanent housing. But that's how it sort of played out in many communities, and I think we're at a point where we've learned a lot of sort of new ways of doing business that suggest that we might want to look at things differently. So in the early 2000s, an effort began to move the continuum of care, which came about in the mid-90s, to a sort of different model of delivering services, and we'll talk about that as we go through the day. But the HEARTH Act was passed. It's taken several years for the HEARTH Act's regulations to be developed, but that's occurred. And it's an opportunity now for us to sort of rethink the system. At the same time, just in the last 3 years, with the Obama administration, was the passage, or not the passage, but the development of the federal plan to end homelessness, which is focused on chronic homelessness, veterans, and families and youth. And again, sort of reframing how we ought to be doing business. So I know that the sort of genesis of this conversation really was some concerns about that were being raised by some of the providers in the community that HUD was going in a different direction, and to some degree that's true. But I think, as you'll hear today as we talk, there's some very good reason for that.
Brande, how would you characterize the new model that Fred is starting to refer to?
Well, I think Fred did a good job in saying that it really is shifting from this process that everyone goes through the same process, from emergency to transitional to permanent, into their own market rate housing, into a system that's really more focused on the client and the client's needs rather than the needs of individual agencies or individual programs. So we're having to shift our focus on a continuum level with all of the programs that we work with. We have about 60 different programs that receive HUD funding within the community all across the region. And those are transitional housing programs, permanent supportive housing programs, and supportive service only programs. About 50% of the programs that are within our funding portfolio, has grown from $7 million in 1999 to now $24 million on an annual basis today. And we have about 50% of transitional housing programs within that portfolio. So really looking at kind of doing an assessment of those programs, and are all of those programs within our community meeting the needs of those who need to be served.
Mm-hmm. So I want to pick up on a point that Brande made, which I think is really important, which is, you know, the system as it evolved over the 20-some years really was, you know, that we created organizations and they put a service package together, and you came into the entity and you were sort of forced to go through that, you know, because we're paying for these services, you need that service. And I think what we've learned, just exactly what Brande was saying, is that you know, each individual need is different, and we've learned, I think, a lot about what kinds of services people need, and rather than creating entities that force everybody through the system, is to design systems which allow you to meet a term that's being used, which I'm not sure I'm entirely comfortable with, sort of the right dosage, the right set of services for an individual. And so I think it's matching the intervention with the real need, rather than sort of forcing people to go through a system that they don't necessarily need to go through just because that's being paid for in a certain way.
Right, and you know, that's something I think grant makers can appreciate. You know, some of the buzzwords out there: constituency voice. That clients, the clients we serve, have a voice in the product, the service, the product delivery, the quality thereof, and there's a feedback loop. So I just wanted to, you know, what we're doing housing does have, and what's happening right now is broader in the nonprofit sector under that constituency voice theme. But our practitioners, what does this look like for clients? How do we know that the intervention or the dosage that we're providing is effective and is what they need? How do we know that? What data tells us that?
It comes down to initial assessment coming in, and then you also have to look at the outcome data going out. So your success rate with each intervention to know how well you're targeting the intervention. So my agency, UMOM New Day Center, has, depending on how you characterize an intervention, we have between 9 and 12 housing interventions. And so you can look at the higher functioning clients and match them with the smaller intervention, which is less expensive, takes less time, and ends their homelessness more quickly. And that makes sense to do that whenever we can. And then the clients with the most intensive service needs, should I be looking at you or them?
Right here if you could.
No, that's really the clients with the greatest complexities, who have the most barriers, are the ones that we should be using the most intensive services with. And I think in the old model, which has already been alluded to, I can just, for UMOM's purposes, our transitional housing used to be reserved for those families. I called them the shining stars, the ones who were doing everything right, who met all their case plan goals, who were clean and sober, who were employed. Those were the families that we gave the greater intervention to, but they weren't the families who needed the greater intervention. So when HEARTH came out, we took a critical look at that and we changed the way we do business. We completely changed our eligibility criteria for that particular program, and now it's strictly based on need. So it's the families for whom we absolutely cannot end their homelessness through any lesser intervention. It's the families that are really significant barriers, who we need more than 120 days in emergency shelter, or who are ineligible for a rapid rehousing program. So if there's no other way, those are the families we're working with. And even then, we used to say transitional housing is a 2-year program. So families would come in and kick off their shoes and save some money and hang out for 2 years. We're not talking about it that way anymore. We're saying that we're using this intervention with you because we couldn't do it in 120 days in emergency, but you're only here until we can end your homelessness. And so although they can contractually stay for up to 2 years, our average length of stay is less than a year in that program. So it's just the right amount for what they need, and it's very much based on like a medical triage model. That if you need stitches, and you might need stitches in your leg rather than a knee replacement.
You don't want them to go to the emergency room for stitches.
Right, right.
So I'm assuming that you're seeing your cost, your service impact, the number and the quality of those outcomes has increased while your costs have decreased. Is that a fair assumption on a per unit or per person basis, because you are able to provide less expensive interventions for some people?
I think that would be the impact ultimately to the system when we get to that point.
When we get to that point.
I can only speak to UMOM internally, and we just consider the needs are much greater than the resources we have to offer. So we continue to have wait lists, and we're fully utilizing every intervention we have. So our costs haven't gone down, but where the costs are greater, and I'm going to throw out some very rough numbers here, but if we've looked at the cost to actually end homelessness with each of the interventions. So we're only looking at the cost for successful exits, so they've left the intervention for permanent housing. And it's running about $6,000 for rapid rehousing, but rapid rehousing is also the highest functioning families. It's running around $11,000 for emergency, but the emergency families are the ones who have greater complexity than those in rapid rehousing. And it's running more around $25,000 for transitional housing, which you want to spend more money the longer time on the families who truly need it. So if you're misusing the most expensive intervention on the families that we could have resolved for $6,000, then you're not making good use of the resources you have available.
And then you talked about before we got here today, just the conversation that's happening out there in the States of big data and what do we measure, and are we comparing apples to apples and all that good stuff. And you want to talk a little bit about how long do you track some of these the data and the success, pay for success, and the apples to apples concerns that you have raised?
Sure, I can talk. In HEARTH, they very clearly outline the outcome measures that they want to be impacted. And I can tell you as a provider, they all make perfect sense to us. It's things that, at UMOM we used to have 53 very discrete outcome measures that were not outcomes, they were outputs, like, are we patrolling the grounds sometime? Are we meeting with somebody, within 24 hours after getting a dirty drug screen, or things that really didn't work directly tied in homelessness. So we threw away our 53 outputs, and we're looking at now 7 outcome measures that are directly measuring the things that are most important, such as exits. When they leave us, do they go into permanent housing? From emergency, that's 40% of our families needed only an emergency stay, and they go right into permanent housing. From transitional, it's closer to 70%. That's a really important outcome because that tells you you've ended homelessness for that family. Employment is another one. We're tracking, do they exit with employment? And so to your point, when you look at the outcome measures as funders and you're comparing one program to another, you might look at our transitional program, which I just explained. We've changed the eligibility criteria and we've really targeted that intervention. If you look at another program in the community, they may not have targeted it the same way as we are. So our employment rate when we first started tracking it was 10%. Because we take only the most vulnerable families into that program. We've worked very hard to raise that percentage to 22%. So 22% of the families are exiting with employment. And considering they're the most vulnerable families, we're actually proud of that number, although it sounds low to you. One of our community partners boasts a 95% employment rate. And so it sounds like at first glance that maybe they're really performing a whole lot better than we are. But the reality is that employment is a prerequisite to get into their program. So they are only taking families who already have employment. And therefore, that makes the 95, that's actually 5% less than for them. So it's important for funders to focus on the successful outcomes, to shift from outputs to outcomes, but it's also important to know that you're comparing an apple and an apple and realize that there's always a story behind the numbers.
And that's just a good reminder of what's been happening in the nonprofit sector for a while, the logic model, the theory of change, the inputs, outputs, outcomes, impact, and being very clear about those metrics and what they might mean, and especially when you benchmark them with other entities or industry standards. So thank you for that reminder. Now, Dede, as we got started here, you were talking about the success and the challenges of Encanto Place and what's been what's been happening here, happening all at once. So when we think about evaluation and success metrics, and we're at the beginning of a very challenging process. So I want folks to hear a little bit about your work here.
Be happy to talk about that. And I wanted to say a little bit about the reduction in cost. And sometimes the reduction in cost is easier to quantify in other systems of care. You might not reduce it in housing, but you're reducing it in healthcare, you're reducing it in criminal justice system, and those other, there's other systems. So as we look at what we're doing, when we're doing a better job in housing, you might not see the reduction there, but you'll see it other places. So how do we quantify that? So I wanted to start with that. And I think Native American Connections, we've been a housing provider for 40 years, and I don't think a lot of people know that. They think of us probably as a healthcare organization because we provided housing as part of our integration of wellness. So all this talk about integrating housing and healthcare is how we were founded in 1972. So I've been working there for 34 years, and the 6 months after I started working in the healthcare side, and we were discharging people back to the community, and they were relapsing in 24 hours. I went, this is not such a good thing. So I'm a believer that housing stability affects is the anchor to a person's, whether it's an individual or a family, it anchors their wellness. And and I've recently, and I know I haven't got to your question yet, but I've recently told our staff we're defining ourselves as a hunger organization because we feed about 400 people every given day. We have 4 commercial kitchens. And I think if you thought of Native American Connection, for one thing, a lot of people don't know who we are or what we do, but we have 4 commercial kitchens. And at Home Base, Guiding Star, Indian Rehab, and Stepping Stone, we're feeding people 3 meals a day, 7 days, every single day. And here at Encounter Point, we don't have a kitchen, but when I realized why we needed to define ourselves as a hunger organization is once we housed 54 chronically homeless, medically needed people and got them into housing with their backpacks in a bed bug box, by the way, free of bed bugs into their unit, they were hungry. And even though we had kind of stacked their little kitchen with some, some food and filled the refrigerators, it was really quickly came to us that we had a hunger issue. So I think you can't separate those. So I'm going to tell you a little bit about Encounter Point. As Mattie said, we do use the HEART assessment tool, and I promised Amy that I would talk a little bit about collective impact. When the United Way began talking about changing the conversation, and I think words are really important, when the United Way started talking about changing the conversation from managing homelessness to ending homelessness, I wanted to be a part of that, and I'm sure you did too. That as providers, we want to, like Fred said, we're going back not to celebrate that we've been in business for 30 years, but that we've done good work, and I think we'd all like to end homelessness. So when the United Way started talking about ending homelessness and they started their institutes, we were one of the first organizations to sign up and say we wanted to be part of that. And so we had this wonderful opportunity about looking at ending homelessness, the way we design facilities. When you talked about constituency choice, United Way organized a group of people to go to Salt Lake, and we went to Salt Lake, political people, architects, financing people, housing providers, and we went to a community that was using the Housing First model to end homelessness. And so we went to look at a best practice model that was working in another community that was somewhat similar to Phoenix. And we found that there was a model that was working. And part of that was that as you began to look at ending homelessness, you needed political support. And Councilman Thompson Plott was actively engaged in the effort here at Housing First. The Devonshire neighborhood came together with the United Way and Native American Connections and our Council of People, and we actually met in our home-based facility, which is right behind here. It is our only transitional program, and it's transitional housing for homeless youth. Everything else we do is permanent housing. We made that shift pretty much years ago to permanent housing. And we met with the Devonshire neighborhood, and we said, we're going to take the most chronically homeless, the most medically needy, and we're going to build a new facility, we're going to put it in your neighborhood. And we had unanimous support. It didn't happen quite like that, but we ended up with unanimous support. We usually had that political support. We had to learn a lot about feral cats. And we had to learn how to humanely work with PetSmart and community partners. And we learned a lot about how you design. If you notice when you come into Encounter Point, it's a single point of entry. So we have 54 of the most chronically homeless, medically needy people living here. These are people that did not access services. They weren't even, some of them, going to CAPS. You actually had to do street outreach. They were part of the H3 group. They were people that weren't even coming into CAPS. They were showing up nowhere because they lived under a bush. And we ended up doing street outreach by bicycle, along the canals and in the parks, and building a relationship. And we promised the Devonshire neighborhood we would focus in this neighborhood. And this is a historic Native American neighborhood too, with the Indian hospital and the Indian school. And so 40% of our demographic here is Native, and we're really happy about that. 40% is Native, 40% is Caucasian, 10% Hispanic, and 10% African American. And so, I'm going to tell you a little bit. So we brought them and we opened up on January 1st, and we had all 54 units that are their low-income housing tax credit with Section 8 vouchers. And if you know anything about the low-income housing tax credit, it comes out of the Internal Revenue Service, and the paperwork is about this thick. And do you know how much paperwork and identification homeless people have, particularly when they're chronically homeless? None. So for us to lease up and to meet all the Section 8 requirements, all the low-income housing tax credit, and be leased up in 9 weeks, we're fully occupied. And so when I show you a unit today, you're going to see an occupied unit because we don't have any vacancies, and we haven't had a turn since we opened of people that haven't been housed, some of them in 15 to 20 years. Wow. So the barriers, and I just want to say, one of the reasons why we developed emergency transitional housing before we went to permanent housing is so many of our funding sources, the barriers come, I'm going to just say not from the program and the providers, although I think UMOM and NAC might be a little bit different than some of the other providers. We would put them in transitional housing as we work to clean up their criminal background because they couldn't get a voucher. And the people we house here, I'm going to just tell you a little bit. So we have 54 people here. Only 6 of them are on access. So only 6 have medical insurance. And these are the most medically needy. So we have some of the Dignity Health Study, the $1 million emergency room users here. But that doesn't change when they come here. They're still here without insurance. And only 4 had an SMI diagnosis. We have 24 people scheduled for SMI determination. And I met with some of the SMI. We're a behavioral health provider, but we're a GMSA provider. It's General Mental Health and Substance Abuse. And it's woefully underfunded, and almost everybody in that system is not eligible for access anymore because they're single childless adults. So we have most of our substance abusers in this community not receiving services right now. So I met with some of the SMI providers, and they say, you need to do this and you need to do that. So if you do have somebody enrolled but they haven't received services and they've been dropped, they have to go back and make an appointment with that clinic, get re-enrolled, and then drop from that clinic if their clinic was in Glendale and re-enroll in another clinic. So they're saying, you need to do this, and I'm saying, we're the housing provider, and we're saying, well, anyway. It's really, really exhausting. It's really exhausting, and so lining up the appropriate intervention is really important, but we still need to make sure that we're removing those barriers to entry. And those barriers are criminal background is one of them, no income, so they've come in, and that's why you had emergency and transitional housing. So it's nice to say we're going to put them in permanent housing, but a housing provider say, who's going to pay the rent? Arizona, Fred, you might want to talk about the number of Section 8 vouchers we have and the history around that. So fortunately, here at Encounter Point, we lined up that financing too. Department of Housing was involved in that, but as well as the City of Phoenix, who's providing project-based Section 8 vouchers. So this site has a voucher, a Section 8 voucher attached to every single unit. So fortunately, that no income, we removed that barrier, and they also removed almost all of the criminal offenses except for sex offender and the methamphetamine distribution and manufacturing.
Dede, I want to circle back before I have another question to open up for the group, but you said the reminder of $1 spent in housing may have a benefit in healthcare, or in food security, or in education, or in economic development or income. But you use the word collective impact. Where in what you're talking about is the collective impact piece that you referred to earlier?
So the collective impact, I'll use Encounter Point as the example, but well, I'll use Housing First as the example, the 1,000-unit strategy of Housing First. You have the financial piece with you have Valley of the Sun United Way and their private business partners there. You have government aligned with the Arizona Department of Housing providing the financing for the facility structure, and the cities providing the Section 8 voucher for the financing. And you have this political support that's breaking the way to come into your communities for, to support that Housing First is the humane and healthy way to do that. And so you have private business, and then you have the providers that are working collectively, really for the first time, through the HART assessment, through tracking referral back and forth, looking at some of the outcomes collectively, looking at the design of facilities that we're sharing information, and just the conversation that we're having with the homeless providers along that continuum has really changed the conversation in the community.
That's a big change that's occurred. I was struck by a number of you talking about World Bank announced yesterday end poverty, extreme poverty by 2030. So how the conversation has shifted when you use that big, hairy, audacious goal of ending something like homelessness. What if we were to get $100 million a year for the next 5 years? What would you do with that? Thinking that collective impact, ending homelessness, what would you each say you would do, recommend? If you got $100 million of financial resources a year for the next 5 years in Maricopa County, what would you do with it?
Well, that's a good question. It's a fantasy I haven't even dared to have. I think one of the things that hopefully you've picked up on from a funder standpoint is we're and Brande mentioned this earlier, and Mattie and Dede have alluded to it. Is we're trying to turn the system upside down. And as I said at the beginning, for 20 years the idea was you came into emergency shelter and as Mattie said, some of the families that didn't really need to be in transitional housing were in transitional housing for lots of reasons. But the conversation now is really about turning that system upside down, and as Dede was pointing to, this housing first model, the idea that as many people as you humanly possibly can get into housing quickly upon their arrival at your door, you want to do that. And then for those who, the model that's being used is sort of this rapid rehousing idea that Mattie mentioned, which is the idea that some people just need a few months and they can be back on their feet again. At the end of 6 months, you're going to have a group of people who didn't succeed for whatever reason, maybe you catch them in the screening that Mattie was talking about earlier. But if you don't, then you can look at sort of interventions that are this sort of transitional housing idea of meeting particular folks' needs there. And then at the end of the spectrum are those folks who don't succeed in any of those that may need permanent supportive housing, much like this facility and some of the other ones that Dede has, that provide ongoing support for folks who have serious mental illness or have health issues that are related to all kinds of things. So I guess that's a long-winded answer to your question is, I would like to see that $100 million used to sort of repurpose the system, really think about how we turn the system upside down, and part of that is, like we'll take $28 million from Brande too, or 24 or whatever it is, but really rethinking how we address this and moving from the managing issue to ending, which really I think we now have the technologies to do if we think about it right.
And I've thought about this question before, maybe not with that same dollar amount, but...
and the only reason I threw that dollar amount out there is because collectively in this room, on the annual basis of who the grant makers, including Fred's organization, $100 million is doable a year, because you guys are spending that right now, roughly. Depends on the year, but $100 million is possible in this room alone. Of course, with your paycheck, your paybook too.
My response is very similar to Fred's, and I kind of jotted down some notes before coming in here. But we have transitional housing, permanent supportive housing, and emergency shelter. Some of the things that we need prevention or the diversion, the rapid rehousing funds. We need a lot more rapid rehousing funding. We also need housing first for those who are the most needy, like the ones who've gone through the hard assessment tool and they are the most medically vulnerable and need to be provided with housing first. Also, we do need supportive services funding, because once these people are placed in permanent supportive housing or permanent housing, there are so many different services that they need in order to remain within that housing. And HUD wants to continue to fund housing, but there's a gap, and we need that supportive services funding so that they can remain in their housing. Also, I wanted to talk a little bit about coordinated assessment, because under the HEART Act, continuums are required to implement a coordinated assessment system, and it's a system that more quickly assesses individuals and families and quickly refers them to the intervention in the community that is the best fit for their needs. Currently, there are many different assessments that are done. In fact, I think we did some looking into all of the assessments within the community, and I think there's something like 45 different assessments that are being done for clients. And for clients who touch multiple systems, they're being assessed in many different ways, and they're having to repeat this assessment process multiple times. So in implementing this coordinated assessment system, they'll have an assessment that's done, an initial assessment that's done in the same way in geographic hubs across the region, and then they will be quickly connected with that intervention, those different interventions that we talked about, in a way that will most effectively end their homelessness. Also wanted to mention, we've talked a lot about serving clients that have the most needs, so we're really looking at, one of the biggest changes is screening people into the system rather than screening people out of the system. And we talked about, we have about 50% of our portfolio are transitional housing programs, and we have some great ones who are serving hard clients, but the majority of those programs are serving the, they're screening people out, and they're not serving the hardest to serve client. So we're really trying to look at that transitional housing portfolio, and can we make changes to the way, to who they're serving or how they're serving their clients, and then maybe reallocate or repurpose funding from those programs and helping them shift into a more effective way to end homelessness rather than managing it like we talked about.
You know, Lou had asked what's happening in Southern Arizona. That coordinated assessment, according to intake, is taking place across that conversation on how to do that across Arizona, certainly Pima County, that's taking place. And that's being driven by what's the best, most efficient way for the client to get the service or intervention they need without having to work that very complicated system. Brande, could you give us an example? You said for the $100 million a year for the next 5 years, you would need like more investment in prevention services and supportive services. Give us like examples of both of those. What are prevention services? What are supportive services?
Well, one of the things that I don't think we have enough prevention resources in the community. So under coordinated assessment, one of the things we're hoping to be able to do is if someone is looking for a resource, they may not need to go to emergency shelter or transitional housing or permanent supportive housing. They may need just a short or medium-term rent assistance and be able to remain housed without ever having to enter the homeless delivery system.
Right.
So rapid rehousing type of programs, rent assistance, utility
Good
assistance.
example. Utility assistance. Okay.
Mm-hmm.
And then supportive services. Give us a couple examples of that.
Well, and I think Dede and Mattie could probably talk a little bit more about the supportive services piece, but I'm sure every client that they serve has different needs, and especially when we're talking about screening people into the system who have medical vulnerabilities and who've been on the streets for, like you said, up to and over 20 years. I mean, the supportive services, I think, can be endless.
Right. So this side of the room, that's 50 million of the funding, and the other 50 will come. So how would you spend that? Brande's 50 million. How would you spend it, Mattie?
Okay, well, I'll start by just echoing both collective impact and coordinated assessment. When I think of collective impact, I actually think of coordinated assessment, because just as I've talked about in our own little UMOM arena, we're really trying to use every intervention. We're maximizing every intervention we have and making sure it's the right investment for each family. If we were doing that on a systems level, it could be an amazing impact if we made sure that the transitional housing, the more expensive intervention, is only being used for the people who actually need that. Then it would free up a lot of resources for everyone else. And so I think that's the first step, is to really figure out together how we can maximize the resources we already have. I think the second thing we desperately need is some sort of a really intensive community needs assessment. For somebody, my sense is that in family homelessness, that probably 60% of the families could end their homelessness with rapid rehousing alone, which is the least expensive intervention. But that's just my sense, and so we really need to know that for sure on the grand scale of the whole community. Really, what are the needs? What percentage really need permanent supportive housing, which is the most extensive intervention that's here at Encana Point? My sense is that it's probably 5% of the homeless population, but we don't actually know those numbers. So until we can start working together as a system, triaging and assessing in the same way, measuring the same outcomes, I think it's really hard for us to judge that. But that could be really powerful, to have a community needs assessment that says you really need to invest 50% of the dollars in this intervention and 30% of the dollars in that intervention. So that's my second point. And then as far as where the gaps are, and this will echo some of what Brande has already said about support service dollars, but one of the new models that we've just recently impacted is called Family Critical Time Intervention. And it's a national best practice that allows the services to follow the family out into the community. So I would guess there are some people in this room who have had an elderly mother or aunt, or maybe a teenager move out of the home, who you have not just cut the strings and been done with them. You've actually had to help them kind of get settled in their new arrangement, wherever that is. And whatever you would naturally do for that person is what many of our families need us to do. So we're actually, our case manager is staying with them, following them into the community, making sure they know how to access medical care, they know how to navigate the public transportation system, they know where the nearest grocery store is, they know how to keep up with their DES benefits, etc. So things you would naturally do for your own family member, they're disconnected from anyone who can help them with those things. So that piece of that ongoing stabilization factor, no one is funding. That's something that we're doing on our own, and it's such a critical piece to keep that family housed so they don't come back to us. And it's much more cost effective to keep them stable where they are rather than have them fall back into the system and start the whole process over again. So that is one support service that is currently a gap. Another is child care subsidies. I can tell you in family homelessness, it's just killing us. There's 8,000 kids on the wait list for the DES subsidies. If our families don't have child care, then they can't work. Most of them work in very low income jobs where they can't afford the child care anyway, and it's just really, it's really hindering our ability to get them into a sustainable, permanent situation outside of the homeless system. And then I'll just say that support services, 60% of our adults have no GED or high school education. Without a GED or high school education, it's very hard to make a livable wage to support your family. So we really have to have experts that are helping with GED tutoring, helping them with the testing. We're doing meditation classes. So I have a full-time person that's doing nothing but trying to help 60% of my population get a GED. We also have an employment specialist. We formed an MOU with AWE because they're experts in employment, because we need job development folks on site. That's not our expertise, it's theirs, but it's critical for our families to get them employed. We've recently partnered with Community Bridges to put on site a substance abuse counselor, because substance use and addiction are issues that at least a third of our folks are struggling with. So those support services are a critical part of the package of stabilizing the family wherever they are, whether it's with us or out in the community.
You know, those are great examples of the supportive services. One thing I'm struck by everyone talking about trying to keep people housed where they are and improve that. You know, the image of Habitat is we build new homes, and we do. But nationwide, increasingly, we're looking at how do we help people age in place? How do we help disabled vets? How do we keep people housed where they are and improve the quality of that housing for better health outcomes? For instance, if you can't have accessibility anymore and you're now in a wheelchair, there are definitely health issues. There are health issues with this aging, crumbling infrastructure called housing. We see it in other public infrastructures, roads, bridges nationwide, but we have this horrible underinvestment in the current aging housing stock. Phoenix or Arizona is a good example. Much of the housing came up right after World War II. So it's 50 plus years, it's falling apart, it's substandard, one or more systems don't work. The iceberg that is out there in the community with housing is how do we keep quality, healthy housing happening for vulnerable populations, many of which are aging seniors, and what's the investment to do that? That's an unmet need. So I could probably spend $100 million a year just on that. Yeah. But Dede, there's a couple
I was hoping I get to spend my money.
How would you spend $100 million?
Well, first of all, I think I'll give you a real life example. So there's an awful lot of duplication out there. If I had my own world to start over again, it'd be really nice. All of our funding comes to us in buckets. You're funded for food, you're funded for housing, you're funded for healthcare, you're funded for this, and it's very prescriptive. And it would be really nice. We get to dream. It'd be really nice if a person came in and you could serve that person whatever the need was, without all. So that would be one thing. That would be really nice. I think that's might not ever happen, but it would be really nice.
So you'd like $100 million unrestricted?
It'd be love to just, if it's unrestricted, it's fine of how you use it. There's still compliance and requirements around that. And I wanted to talk, I think we're really in a real heavy compliance mode in everything we're doing, and I'd really like it to shift to outcome and results. We are still being monitored so heavily, and I'm going to say we're audited monthly, 2-3 days out of a month, with the amount of compliance that we have, all the inspections that we have and everything, and they're very, very much still, we're not in a partnership relationship. I don't know if you feel that way, Mattie, but it'd be really nice if we were outcome and results based and where they came out, and we're all working together, you know, to keep this service as high quality in the community. That's just one thing would be my wish. So home-based youth services is just right there. They touch each other. And one of the funders in this room funds home-based youth services, and it's a homeless transitional housing for youth. And we measure, we have 3 measurements at home base. When a youth is homeless out on the streets, and we connect with them, and we have an outreach program, and they come in to our day resource program. So the number of youth that have not ever received services when they're homeless, they come into the day resource center and they receive services. The number of youth then that come into transitional housing who make the decision to actually come in off the streets into housing, and then of those youth who are in transitional housing who've gone into permanent housing. And transitional housing, it's our only transitional housing, allows you to stay for 2 years, and the average length of stay is about 6 or 7 months. Because you're moving that person along, you know, a self-sufficiency model, and you're measuring that. And so we have this young man named Ruben, and Ruben was homeless, went to home base, and when Ruben completed home base, he went to transitional housing. He was then looking for permanent housing, and he went to Devine Legacy. And I don't know if you know that Devine Legacy is one of our permanent housing. And so Devine Legacy, I want to talk about a few little strategies, is on the light rail. And Fred, I'm probably surprised you didn't bring up the transportation index. But if you locate a family on the light rail, it reduces their, and they don't have a car, it reduces their cost of $10,000 a year. That's the transportation index in this community. And that's more family stability. They can pay their rent, they can do things for their kids. So now you're located on public transportation. You have access to jobs by being on public transportation. And Devine Legacy opened up about 1.5 years ago. And when we did our annual certification we only had 1 turned unit. So it has 65 units occupied with 1 turn in 1.5 years, because we're on the light rail, we provide support services, and at Devine Legacy, Futures for Kids coming in. So it's after school tutoring. They're not needing SOAR to come and get them on benefits and, you know, the critical services that are here, but they're still needing support services, Future for Kids. They more need those family support services. We have some domestic violence services, and they're more family need services, but I don't care how and what level of care these families are, they still need support, some level of support services. And those can be, you know, they become higher level services where the quality, it's more about quality of life for families. So we have the same model as UMOM too, is we co-locate other nonprofits that provide the services that we don't. We know what our core service is, so we have MOUs with about 30 different nonprofits. St. Joseph the Worker comes in and does our workforce development, and Catholic Charities does our financial literacy and education, and St. Mary's does our kids corner and our after school feeding. And I could just go on and on with the community partners. But there's still that coordination, so we have those positions just like Mattie. Nobody funds those positions. Those coordinators are coordinating those MOUs to get the community partners to come in, to, you know, set up the services. We even have some of them that we provide free housing space for, so they're co-located in our facilities. But I think that's been a little bit shift too, Mike. You're really beginning to see us try to utilize those, the best use of the resources, where we're not duplicating services and we're really working together.
But that kind of collective integrated impact requires some cost structure to coordinate it all. Is what you're saying.
Absolutely. Childcare is, it really is the core services. Childcare, transportation, jobs that support families and housing.
Well, we've said a lot. I think they've kept the acronyms, the dirty talk, to a minimum, so I appreciate that. But if there are some definitions you need or acronyms and any questions, let's open it up and just see what kinds of questions you might have.